Hello, everybody. This is the lecture in acid-base disorders. What is acid-base hemostasis? The pH of arterial plasma is normally 7.4. This figure is to be recognized by memory, corresponding to a hydrogen concentration of 40 nanomole per liter, and under normal circumstances, hydrogen ion concentrations do not vary outside the range of 37 to 45 nanomole per liter. That is, the pH is maintained on 7.4 to 7.35. So abnormalities of acid-base balance can occur in a wide range of diseases. The increase in hydrogen concentration causes acidosis with a decrease in pH, whereas decreases in hydrogen concentration cause alkalosis with a rise in pH. So presenting problems in acid-base balance, disturbance, metabolic acidosis, where blood hydrogen ion concentration more than 40, but in respiratory alkalosis it is less than 40, and metabolic alkalosis less than 40, and respiratory acidosis it is more than 40. We have compensatory responses and the predicted compensation. The body used in any insult to the metabolism, the body will compensate. There is a compensatory response and predicted compensation. The metabolic acidosis can occur when an acid other than carbonic acid, due to CO2 retention, accumulates in the body, resulting in a fall in the plasma bicarbonate. These are causes of metabolic acidosis with normal anion gap, with increased anion gap, and with exogenous acid load. This table is to be well recognized, well memorized, because it is reflected on our clinical practice and management in our clinical office. Clinical features include normal anion gap metabolic acidosis is usually due to either to bicarbonate loss due to diarrhea, where the clinical diagnosis is generally obvious, or due to renal tubular acidosis. Renal for R, T for tubular acidosis. Presentation of increasing anion gap acidosis is usually dominated by clinical features of the underlying disease, such as uncontrolled diabetes mellitus, kidney failure, or a state of shock, or may be suggested by the clinical history of starvation, alcoholism, or associated symptoms, such as visual complaints and methanol poisoning. What investigations that are beneficial in such conditions? Blood gas measurements. This is arterial blood gas analysis. It is available almost in all emergency units and rooms. This is important because it reflects the acid-base balance. Measurements of creatinine, electrolytes, and bicarbonate. The anion gap defined as a numerical difference between the main measured cations, sodium plus potassium, and the anions chloride plus bicarbonate, is about 5 to 11 millimole per liter. This should be recognized. These figures are to be memorized. This gap is normally made up of anions such as phosphate and sulfate, as well as albumin. So these are important: phosphate, sulfate, as well as albumin. The renal tubular acidosis should be suspected when there is hyperchloremic acidosis with a normal anion gap in the absence of gastrointestinal disturbances such as diarrhea or vomiting. The diagnosis can be confirmed by finding an inappropriate high urine pH that is more than 5.5 in the presence of systemic acidosis. In patients with raised anion gap, metabolic acidosis show features of the underlying cause, such as reduced GFR, that is glomerular filtration rate, in kidney failure, and raised urine or blood ketones in ketoacidosis. In diabetic ketoacidosis, the DKA, blood glucose is elevated, while in starvation and alcoholic acidosis, blood glucose is not elevated and may be even low. Measurement of plasma lactate is very helpful in the diagnosis of lactic acidosis when values are increased over the normal maximal level of 2 millimole per liter. How would we manage such cases? We should know and identify the correct and the underlying cause when possible. Always in your management, you should look for the root cause. Without knowing the root cause, we will do nothing. We will throw stones in the dark. The acidosis and renal tubular acidosis can sometimes be controlled by treating the underlying cause. Usually supplements of sodium and potassium bicarbonate. So bicarbonate are also necessary in type 1 and 2 renal tubular acidosis to achieve a target plasma bicarbonate level of more than 18 millimole per liter and with normal potassium. In type 4 renal tubular acidosis, loop diuretics that are potent diuretics, the thiazides or fludrocortisone, as appropriate to the underlying diagnosis, may be effective in correcting acidosis and hyperkalemia. And by the way, hyperkalemia is lethal. Hyperkalemia is risky to life. It causes death because it causes cardiac dysrhythmia. So it has to be managed soon as possible as an emergency. What about metabolic alkalosis? Looking to metabolic alkalosis, characterized by increase in the plasma bicarbonate concentration, plasma pH. There is a compensatory rise in PCO2 due to hypoventilation, but this is limited by the need to avoid hypoxia. The patient will start hypoventilate. Classical causes include primary hyperaldosteronism, Incoll syndrome, Cushing syndrome, and glucocorticoid therapy. Occasionally, the overuse of antacid salts for treatment of dyspepsia produces a similar pattern. It is restlessness followed by lethargy. Patients are very tired, and there is compensatory hypoventilation. Causes, I want you to memorize this cartoon. This cartoon reflects the metabolic alkalosis signs and symptoms. What is the pathophysiology in metabolic alkalosis? Best classified according to the accompanying changes in extracellular fluid volume. Hypovolemic metabolic alkalosis is the most common pattern. This can be caused by sustained vomiting, in which the acid-rich fluid is lost directly from the body, or by treatment with loop diuretics or thiazides, that is overdiuresis. Normovolemic or hypervolemic metabolic alkalosis occurs when bicarbonate retention and volume expansion occur simultaneously. What are the clinical features? Apart from manifestations of the underlying cause, there may be few symptoms or signs related to alkalosis itself. When the rise in systemic pH is abrupt, however, plasma ionized calcium falls and signs of increase in neuromuscular irritability. There will be, as seen in the photo, such as tetany may develop. This is tetany, a patient with tetany due to plasma ionized calcium fall, and this is the sign. It is tetany. It is carpopedal spasm. Diagnosis can be confirmed by measuring the electrolytes and arterial blood gases. A facility always and should be available in emergency units. Management of metabolic alkalosis with hypovolemia can be corrected by intravenous infusions of saline with potassium supplements. This will reverse the secondary hyperaldosteronism and allows the kidney to excrete the excess alkali in the urine. And metabolic alkalosis with normal or increased volume treatment should focus on management of the underlying endocrine cause. Always look to the underlying etiology. Always look to the root cause. Thank you for attention.